Thursday. I always have to look at my January 12th, and we're here in the House Healthcare Committee with Department of Mental Health. So we've done a lot of broad overview this week. Now we're going to start looking at the departments that we work most closely with. We'll do some broad overview, probably, drill down into some things. And this will not be the first time we see Department of Mental Health representatives. So we're hopefully going to get along really well this year, which would be great. I also want to just let everyone know that Representative McFawn is going to be a little late. He let me know he is over in Human Services this morning. But what I think we'll do is start with introductions because we have quite a few new people, and then we'll turn it over to you, Commissioner, for introductions. So I'm going to start with Bobby this time.
Bobby Farley-Rubio from Caledonia One.
Great.
Barnett, Reigate, and Waterford.
Nice to meet you.
Joe Andriano, I'm from Orwell. I represent Orwell, Shoreham, Whiting, Sudbury, and Hubbardton, Madison, Rutland District.
Alan Dwyer, representing Enosburg and Montgomery.
Ryan Chena from Burlington. Good to see you again.
Good to see you. Alyssa Black, Northern Essex. Great to see you all again.
Lori Houghton, City of Essex Junction.
Oh, who me? Representative Cordes from Lincoln area, Bristol. Good morning.
It's so good to see you. It's from when you ski.
Leslie Goldman, we've met from Rockingham, Bellows Falls area. Good morning. Good morning.
Representative Rob Peterson, Rutland District 2, live in Colorado.
Good morning.
Great. And would you like to do introductions of your team?
Sure. So good morning. Thanks for having us. For the record, Emily Hawes, Commissioner for the Department of Mental Health. And with me is Deputy Commissioner Allison Crump. Also, we have Nicole DeStazio, our Policy Director, and Alex Karambalas.
You're close, correct.
You did it, Commissioner, not me.
What's your job now?
Senior Policy Advisor.
Okay, thank you.
Great to see you all.
Thanks, Alex.
Great. And so just to set expectations for the committee, I'm going to switch to first names, if everyone's okay with that. If you're not, let's talk offline later. But for this meeting, we do first names. And just remember, we've been pretty lax about asking questions, but if we can just funnel the questions, look towards me when you raise your hand to make sure that I have everyone in line who wants to speak rather than just looking directly at Emily and Allison. So that would be really helpful just to make things flow. And during the presentation, do you want us to hold questions until you pause, ask questions throughout, whatever works for you?
I think my first response is I'd like questions as we're going through, but knowing that we have a lot of slides, so I want to make sure that we get to them all because it's all, very important work to get to. So if we can kind of balance that as we go through, do we have an hour?
You have an hour and a half.
Hour and a half, okay.
Great.
And like you said, this won't be our first time coming together, so we can always answer questions afterwards.
Great. All right, let's get started.
So I'll start with just a brief overview of our mission. So the mission of the Department of Mental Health is to promote and improve the health of Vermonters. The department resides under the Agency of Human Services, and we share the same mission, which is to improve conditions and well-being of Vermonters and protect those who can protect themselves. Our vision, mental health will be a cornerstone of health in Vermont. People will live in caring communities with compassion for and a determination to respond effectively and respectfully to the mental health needs of all citizens. Vermonters will have access to effective prevention, early intervention, and mental health treatment and supports as needed to live, work, learn, and participate fully in their communities. So what we'll present today is all under the guise of that critical mission. So I'll first start with that DMH is responsible through statute for the mental health system of care for Vermonters. We are also, as a department, composed of 265 staff. About 200 of those positions operate our two facilities. The Vermont Psychiatric Care Hospital, which is a 25-bed hospital located here in Berlin. Those folks are admitted involuntarily, so they're under the care and custody of the commissioner. And then we also have Middlesex Therapeutic Community Residents. And then we have around 65 central office staff, so.
So may I just ask, so the 200 faculty staff, are they clinicians?
The 200 facility staff will be, is a mixture of RNs, mental health specialists, recovery services, social work, psychology, operations, facilities, an admissions team, reception. It's all the positions that it takes to run that facility. And then we coordinate with BGS for custodial services.
And BGS is, we're gonna do,
You bet.
yeah.
Buildings and general services. This will be a good test for me too.
For all of us.
Yeah, and that's the same type of positions that you see at our therapeutic residence, which is in flux. So we currently have a 7-bed facility in Middlesex that will be transitioning to Essex in hopefully around April. So that will grow to 16 beds, and so staff numbers will grow with that to support.
So that's gonna be ready in April, you say?
Well, that's the projection, yeah. There's a potential furniture delay, but we're still committed to getting there. And if we have to take some old furniture with us and fit it out temporarily.
Is that on time of the original projection?
Yeah.
It is, yeah, I didn't know, I hadn't been following that.
And if I can just add, I have a question, but I'll make a comment first. And I think Melissa has been there too, but it's obviously in our backyard. And I was there this weekend on a walk because there's trails right by it and it looks amazing. And I think you think the same thing, like it really.
They've done a really nice job.
Yeah.
Really great job.
Yeah. So it's exciting to see it happen. Can you just explain therapeutic in the, flow of mental health?
Sure. And so we'll get to a slide that will define the different levels of care that our system has. And we can go into a little bit more detail around hospital level of care, our different acuity of beds across the system, and talk a little bit more of that because I think the understanding of that is really.
Okay. Leslie?
Just to remind me, I remember that we sort of started at 8 beds, but we're sure we were going to go add the other 8. Can you remind me about that?
Sure, it grew to 16.
Yeah.
So the original, it's a 7-bed facility in Middlesex, was out of the response to Tropical Storm Irene. And so that is made out of temporary FEMA shelters, or FEMA trailers, excuse me. And so the transition to a permanent, more therapeutic designed space and the relocation to Essex.
And we did vote on 16 beds in this committee.
We started with 8, but then I remember there was going to be 2 wings.
Right.
But then, so we landed on 16 in the end.
Yes.
Thank you.
In all the 16, the wings, there's not 8 that are one type of facility and 8 to the other, they're all the same?
They are all the same.
Okay, all right. No.
Great. Sorry. First slide. Let's keep going.
So DMH also works with a budget of about $287 million. This is a brief snapshot of the breakout, and I imagine we'll get into more detail as the session moves along. We oversee 10 designated agencies and 2 specialized service agencies. So our designated agency system is your United Counseling Services, Rutland Mental Health, Claire Martin Center, that group of folks. We also, like I mentioned, run the Vermont Psychiatric Care Hospital, as well as the Middlesex Therapeutic Care Residents. And then, like I said, that will change into River Valley. And we're hoping still for April, like I said, April 23. We manage several contracts and grants to peer organizations. We have contract for forensic psychiatry, psychiatric consultation across the system in primary care. And then also contract to conduct analysis of population level data related to mental health. And then, of course, we partner very closely with just about anyone that you can think of. So
Joe, I think you had a question.
Yeah, so I'm following along on the PDF that was provided on the website, and I'm noticing as you go through these bullet points, the pie chart and the map that you had are not showing up on this PDF. And
Oh, okay.
I'd really love to have a copy of
You
that
bet.
pie chart in particular, so if you could send both that
Absolutely.
pie chart and map, that'd be really great. Thank you.
Yeah, that sounds great.
Yeah.
Thank you.
Thanks.
Okay, so I'll briefly talk about the different types of community mental health programs and
Oh,
services.
actually, correction, I see it was just on further pages here. Just
Oh, gotcha.
My apologies.
No, that's okay. All right, so
Okay, you're right. Same
designated,
problem.
our community mental health programs serve adults in a couple of different ways. We have adult outpatient programs. Those are folks who are experiencing mental health challenges. They include clinical assessment, individual and group therapy if that's indicated. And then there's also CRT, which is community rehabilitation and treatment. The CRT program is also for adults, and that's for adults who need additional supports from their treatment team. So those are the folks who have the most serious mental illnesses, such as schizophrenia, bipolar, major depression. And let's see. I want to make sure I'm hitting everything in there. Oh, yeah. Like I said, they work with a assigned treatment team that includes therapist, case manager, access to psychiatry. We also offer services through Children, Youth, and Families, or CAFU. That's services delivered to youth and their families, along with supports within schools. We also have emergency service programs throughout the designated agency system. Those folks are responding both to the community and emergency rooms to support folks in crisis. And then we do advocacy and peer support across the system. Anything to add in there?
I think. Go ahead.
Now, I have a question on the children, youth and families. It's no news to you that we have a problem with emergency department wait times. I went to, not this past year, the year before, went to Rutland Hospital, Rutland Regional, and met with the emergency room folks. And one of the solutions that the lady there had, the director had, and I don't know the acronym, but it's a system where the kids, youths would get psychiatric care from a child psychologist, telehealth wise. And there's an acronym for that, and you may know it, I don't. But I wondered if we've made any progress in that arena, because at some point we got to do something here. And it seems to me that if we had, I know we're short of psychiatric help, but if we had a location where there was a person or two that dealt with children and could solve some of their problems, at least the basic problems, via telehealth, that would be money ahead. Any movement there? Any?
Sure, we can talk about a few things that we have happening. So we did expand telepsychiatry system-wide throughout the pandemic in the last year significantly. And actually, I'm doing a meeting with folks tomorrow to kick off another round of expanding access to telepsychiatry, because we also acknowledge that, especially in our hospitals that don't have psychiatry on site or a psychiatric unit, access to psychiatrists becomes even more important. So we've done some great expansion with that. We also are working on a couple of projects for alternatives to EDs, so that we can sort of intervene or support folks before they get to an emergency department. And we can talk more about that now, or wait till we get to it later in the slides. Okay, sure.
Yeah, no, okay.
Go ahead. Oh, sorry.
That's okay.
What is the partnership that I believe Dr. Ratu started with UVM and the telepsychiatry for youth?
Sure. And Dr. Ratu, is no longer with us, but we partner with the Chittenden Health Center to do psychiatry there for youth. We have a grant program that gets folks connected to UVM psychiatrists through that partnership.
I think was that perhaps the acronym that he was talking about? What is it?
What's,
Access to child psychiatry, it's V.
It starts with a P.
Well, there's PAC.
No.
No.
yeah, I'm gonna look it up as we go here. I'm gonna try to keep one
And we
eye
can
here,
always
one eye
have Laurel Omland, who's our director of child and family unit, come and talk more about that. And Dr. McGowan, who is our medical director for the youth and family, to talk more about, because it's been very successful.
Well, I mean, I think we need to keep it at the forefront because everybody in this committee gets a report monthly about the number of kids waiting. I just personally, I cannot imagine a kid waiting a week in a hospital. I can't fathom it. It wouldn't be my kid. I know that.
It doesn't help with their treatment. Alyssa and then Leslie.
I just, really quickly, I wondered if Dr. Ratu's position had been replaced and filled. Is it
Yes.
Dr. McGowan?
Yep, Haley McGowan, who is a child psychiatrist with the UVM Health Network. Yeah.
Leslie?
So, Art brought up those emergency, sort of reports that we're getting. I'm not sure if you're planning to speak to those. If you are, I'll wait, or I could ask now.
We will speak to them in a way of how it fits into the broader system. So we'll do a snapshot of what the system looks like, and we can certainly get into some additional information based on what questions are out there.
And we will have a conversation about the data in the future.
Okay, because I get those reports and I'm getting frustrated every time I get it. Because I can't get it. There's what's the action? And so are the reports useful to anybody? A lot of people are doing work creating those reports, but if they don't lead to any kind of reasonable action, then why do it? So that's my question.
And that's exactly the conversation we're gonna have. I've already reached out to Emma Harrigan, who is doing it, and I think she's working with me. So that's on the agenda.
Great, thank you.
All right, so I mentioned earlier in our testimony that we have a slide that talks a little bit about the system of care as a whole and the different levels. So this is that slide. So as you'll see, the bottom, community mental health is our foundation for our mental health system. And so those are your community mental health services that your DAs are providing. So those are your case management services. Those are your therapy services, psychiatry, group, school supports. We also support housing vouchers for adults. And so I think we have a little over 100 of those. We have group home access across the continuum, and then a host of your community support level. So I might give folks an opportunity to sort of digest that bottom level. That's certainly holds the most of our system.
Right.
Did the micro residential homes increase? Is there still one in Addison County?
There's two in Washington County. I don't think there is one in Addison County for youth or for adults.
Oh, yeah.
Yeah, but the
question.
term micro residential is used for the youth residential program in Washington County, and then there's community-based residentials.
The I thought there was a micro in Addison County at like.
There is an adult crisis center with CSAC. And then they also have a couple of crisis beds under Hill House. And those serve adults. And where that would be on this continuum is the next step up. But we can connect and just make sure that we're talking the same language about who you're thinking of.
Daisy?
I love this graphic and love to see that it's updated. I'm not familiar with the micro residentials. I wonder if you can tell us a little bit more about what those are.
Sure. Do you want to take micro residentials?
Yeah, the term micro-residential is really the term we use for a youth residential program that's community-based. So there's one in Washington County, and then NFI also has a micro-residential. And that's a space where for youth who often are in custody, that's been part of the issue, is if you have a youth who might be able to be served in the community, but they don't have a stable enough placement for them to be held safely. So they don't really qualify for a hospital. They don't need inpatient anymore. Or they went to inpatient and they're clinically ready to discharge, but they need a really safe space to discharge into to prepare them to go back into a home, whether it's with their biological parents or a foster placement. So those residential spaces are usually, youth are held for anywhere from about 90 to 180 days. It's that type of length of stay to really get somebody stable and ready to discharge back to a home placement. Yeah, and we'll talk a little bit about some of the stabilization we've done, but I will name those programs in particular have been hit incredibly hard by staffing crisis because they're 24/7, they require a lot of staff, and the youth who go there have a lot of needs. And so we've lost a lot of staff, and particularly in those programs. So we're trying to target, because if they are not well staffed and stable, it kicks youth up to higher levels of care because they're
everything. Joe?
I'm just curious, I keep on hearing so much in the news about our mental health system of care being at capacity. And so I'm wondering, is anything on this chart not at capacity? Is there anything where where we could get someone into something like this right now? Or are we looking at wait times and everything I'm looking at?
That's a really good question. And I think there's a couple of things that go into that. One, based on the needs of the individual. So we have beds available across the system. If you're thinking of access to, say, child psychiatry, that is impacted by waits. We have a psychiatry shortage here in Vermont and nationally. Part of our system also relies heavily on a private providers, and we saw quite a few private providers leave the helping field throughout the pandemic, and so that did put additional strain on the designated agency system. And so it really depends on where you are. Some folks have same-day access and you get hooked up immediately. But you've seen us, hopefully heard of 988. We'll talk a little bit more about that. We tried to expand some services to folks so they can access a brief intervention, when they need it. So there is treatment available throughout our system. And we want people to be reaching out to their designated agency or calling 988 now so that they can get connected.
Thank you.
Mm-hmm.
Okay, keep going. Quick. I want to get through this.
Okay, sorry.
I think we'll have more time, but
This is an amazing graphic, and when I love that thing in the upper right, so I'm beginning to understand. So the DA, I'm interested in the orange group. What's your relationship? How do they get paid? What's your relationship with them? Because we know that's where there's huge bottlenecks of patients, not getting seen.
Mm-hmm.
So I'm curious about that. I think that's where we gave an 8% increase in salary.
To the designated
agencies, and how's that working? And I was just, but if you want to do it later.
and I will say, we're going to have Vermont Care Partners in to talk specifically about how it's working with the DA. So obviously you can touch on it, but we'll go in more detail.
So we do provider agreements with our designated agency system. And so all of that orange is a mixture of Medicaid money, mental health block grant dollars, depending on the particular program. So it's a mixture. They also bill private insurance, self-pay, but we do provider agreements to those agencies, and those consist of performance measures and data quality that we are overseeing as a department. Anything to add from that?
Well, we met with Vermont Care Partners Executive Board just yesterday and asked that very question. And so I think it'll be great for you to talk with them directly, because they certainly have their finger on the pulse. It sounded, what we heard from them yesterday was the 8% really helped, and that they've seen sort of fits and starts with resumes coming in and a higher quality of applicant. And yet, of course, it hasn't solved.
Okay, still a lot of openings too. So, yeah.
Mhm.
Thank you.
Yeah, you're welcome. Do you mind if we go back to that one side? Yeah, I just want to finish calling out our intensive residential treatment programs. And then our secure residential right now, it's like I said, 7, that'll be moving to 8. And then our inpatient system, which operates at about 200 adult beds and about 29 youth beds. We've done some great work with the Brattleboro Retreat over the last year, and so they have one unit that they will shift from adults to youth depending on the system needs, which has had some great impacts on our wait lists. Because let's say there's a host of, 5 or 7 folks all in the same general age range, they can get access, they get treatment, and they get discharged. And so sometimes you see those bed numbers flex on the adult and youth side, and that's because there's a unit that we haven't quite figured out how to articulate the data on very well, that is flexible in the needs of the system. Joe?
Are there any intensive outpatient treatment programs in the system? I see some residential ones I'm curious about those.
Yeah. So intensive outpatient, when I hear that, I go back to my substance use days, and to me, that's 10 hours a week of intensive substance use treatment. And there are intensive outpatient programs that are co-occurring throughout the state. I would have my VBH partners talk a little bit more about how that system is operating. But the intensive residential treatment programs are offering treatment all day, every day. And then people also live there. So it's a little more intense than your traditional intensive outpatient program as it relates to substance use. Yeah.
And just for education purposes, so Brattleboro Retreat is the only, correct me if I'm wrong, inpatient hospitalization for youth in the state of Vermont. Correct. About that.
Correct.
Great.
Good, thank you. So like I said, let's see, point in time data from the 10th, 2 days ago. So we had, well, folks can see, out of the 200, about 153 of those were currently occupied, 30 were closed. Those closed beds are typically related to either staffing or acuity. Could also be that there's a cohort of folks who are COVID positive, and there's some adjustments a unit needs to make for infection control reasons. But then there were 17 beds open. And those 17 beds could be a general bed, so to speak. So a unit at, say, Central Vermont Medical Center, and those, or it could also be our highest acuity beds, which are the Vermont Psychiatric Care Hospital. And then we have a unit at Rutland and Brattleboro that also serves folks who are in need of those highest acuity.
So can I just jump in here real quick? One of the things that I've learned over the past 6 years is, I would look at a chart like this and be like, well, we have people waiting in the ED. Why are they not filling these 17 beds? But it all depends on the type of, correct me if I'm wrong, type of staff that's connected to that bed, the acuity of the person. And sometimes the puzzle pieces just don't fit together to put someone in one of those open beds. And I don't know if you want to elaborate on that.
No, I think that that's great. And this is the hard thing about getting a list of beds, because an open bed isn't necessarily an open bed. And so I think it confuses the conversation a little bit, but you summarized that really nicely. So let's say somebody is waiting and they have complex medical issues that can't, and the open beds are at the Brattleboro Retreat or the Vermont Psychiatric Care Hospital. They don't have the access or the medical capabilities to serve folks with complex medical needs and complex mental health needs. And so that would be listed as an open bed, but that wouldn't necessarily be meeting the treatment needs for the individual needing an inpatient placement. that's the easiest, I think, scenario that comes to mind. But of course, there's also someone's acuity, or if somebody is voluntary. Most of the folks who are seeking treatment are voluntary. And so oftentimes, if it's not a facility that they want to go to, they can choose not to go to that facility and wait until there's a bed available closer to home. So that's a complexity in this as well. So I'm happy to talk more about what data works and what shows change in the system. I'm excited about having that.
Yeah. Daisy and then Joe.
I just quickly want to catch that point. You said most of the people seeking treatment are voluntary. It's like actually a vast majority of them are
I think it's
voluntary,
like 90%,
Yeah.
something like that.
Okay.
Does everyone understand voluntary versus involuntary? Should we touch on that? Maybe.
Yeah, let's talk about that.
Yeah.
So somebody who is voluntary is somebody who's willing to go to a hospital for inpatient care, and they meet inpatient level of care criteria. So the Cliffs Notes version of that is they would require 24-hour nursing in order to support them in their inpatient stay. So like I said, voluntary, they want to go, and I lost my train of thought. They want to go and they meet that level of care. So somebody who is involuntary, we have a two-step process through our designated agencies through the screening, and two physicians will screen and confirm that somebody needs hospital level of care and will not go on their own. So they'll come under the custody of me or the commissioner, and then the department will work to place them into a facility that is open to taking that individual. And all of our inpatient units can take folks who are involuntary, but involuntary folks can't go out of state. So sometimes our voluntary system, somebody will say, I want to go across the lake to Champlain Valley, and they're able to do that on a voluntary status, we can't do that when they're under involuntary status.
Great.
Is that helpful?
That's helpful.
Okay.
Thank you. I think Joe still had a question and then Bobby.
I just heard people use the term acuity several times. I don't know what acuity means in this context.
Yeah, great question. Acuity can mean a few different things. You can have medical acuity where your medical symptoms are unmanaged. Acuity most often in this conversation relates to somebody's potential for violence and or a potential for needing medication that might need to be involuntary, I guess I would say. They would need to go through the involuntary court process for meds. And that's usually related to, just very severe symptoms, let's say of schizophrenia. Not all acuity is violence. Some folks are the other side of that spectrum where they're, not participating at all, or we can't get them, out of bed or, so the other side of that is also staff heavy. And so when I think about acuity, it's somebody who needs additional resources in order to support them in the best way throughout their treatment program.
So would someone who needs to go to treatment lack acuity or have, I'm just sort of trying to understand how acuity be used in this context of deciding, as we said a few moments ago, about whether a particular bed, you said that a particular bed, the person might not have acuity or the bed might not have acuity. So I'm sort of wondering, how do we use acuity in this context?
Sure. So let's say somebody is wanting access to an inpatient hospital and they're voluntary. And let's say we have a unit, say at Central Oron Medical Center. They have a unit or a nursing desk that is open. And they also at one point used to share rooms. So somebody that doesn't necessarily need a lot of redirection or have a propensity for violence is there potentially for short term med stabilization and or a brief therapeutic intervention. Those are folks who you would typically see as lower acuity, so to speak.
Great, thank you.
Yeah.
Bobby?
Oh, yeah, my question was about the involuntary. I mean, I think of old fashioned terminology like committed, right? Is this as you said, it's determined by two doctors? Is this ever a judicial?
It does. So that's the beginning piece of it. Then it goes to a judge for a review. And then it would go, and that's an application for involuntary treatment. And then it will go through family court for application of continued treatment. And there, it does go through the judicial process.
Okay, that's what my question was.
Yeah.
Okay.
We're good? Okay. So here I'm going to, we will highlight the department's mental health legislative priorities for 23. I'm going to briefly talk about mobile crisis response, but we do have an RFP that just closed on that. So I'm a little limited in our ability to talk about that. But we did quite a bit of testimony on this last year about expanding access to mobile crisis response. And that is the opportunity for folks to be met by a crisis team in the community. Where they're at versus having to go to an emergency department and be seen by a crisis screener at the emergency department. So we are looking to expand that. We did a pilot in Rutland last year that was primarily focused on youth. It didn't meet the federal guidelines for an enhanced Medicaid rate drawdown. And so we're expanding into what we define now as our mobile crisis response, which does meet those requirements for an enhanced rate drawdown for Medicaid. So I know that I dropped a lot of info right there after I just said I'm not going to talk about it.
I know they were having problems staffing that. Has that been resolved?
They had 2 staff, right? The last we checked, but you may have a more up-to-date info than I do.
It was slow to start, then they did bring 2 staff on. They need more staff to be able to, they're not meeting the hours that they had intended to. So the program is running, not to the hours.
Not to what they want. So how many people are they short? You don't know probably. I understand. Okay, so they're still looking for folks to staff that.
So, yeah.
And mobile crisis, I mean, do they come in a van and drive into your driveway? How does that, explain to me how a mobile crisis response works.
Sure, from a high level, mobile crisis requires 2 folks to respond to an event, and one of those being a peer or person with lived experience.
I assume they're connected with 911. 911 calls them typically.
They don't actually. I know that I think there's some futuristic work that we can talk about. Let's talk more about that after the RFP closes, because I think that once we get into some 988 conversations, those may all start to come together nicely.
And once and we'll definitely have Department of Mental Health back in once the RFP winner, I guess, is announced and we have more specifics about that, so.
Okay, so thinking about, sort of where the department is going, what we've been trying to build and also what we've been trying to stabilize. We're starting to talk about it in sort of these 4 buckets, which is someone to prevent, and if you need something, someone to call, someone to respond, and somewhere to go. And so for someone to prevent, we have it must have been almost 3 years ago now, there was a move to have a director of trauma and resiliency. And so we do have that position situated at the Department of Mental Health, but now they have a partner in their director of suicide prevention. That has been a position we've been really looking forward to having, and something that this committee and others have pushed for. It was a hat that I used to wear, and then we sort of spread it around a little bit, but we've never had a dedicated person at the state devoted to suicide prevention. So now we have this partnership with Trauma and Resiliency and Suicide Prevention to be trying to get a little bit ahead of things and doing some great work out there, both with some of the grants that we have and with department and agency-wide efforts. The someone to call, as we know that all the prevention sometimes, you still need some support. So someone to call, and I'll show you some of the data on this and where we're at. We really did a push for 988. If you're not familiar with it, hopefully you've all heard of it and got that text on your phone that says you'll now have to stop, start using 802. We've had crisis supports 24/7 via phone in Vermont. So that isn't new, but we've had them through your local designated agencies. We have them, so you need to know the number to call depending on what region that you're in. And that at certain hours of the day, you reach a pager line. It's not a person who answers the phone. And so the National Suicide Prevention Lifeline was this other number that was sort of out there, but it wasn't Vermont specific. So around leading up to last year, they actually reached out to us to say, Vermont, are you aware that when people call the National Suicide Prevention Lifeline and they're Vermonters, they're not reaching anyone in Vermont? We said, well, isn't it a national line? And they said, well, yes, but when you call, it says we're directing you to your nearest crisis center. And they're working, they've done a lot of work over the past couple of years to build the infrastructure in state so that when you call, it still meets all the standards. You say you've reached the suicide prevention line, but that the person on the phone knows what the resources are in Vermont and that they can refer you and that you have the system to sort of enter the services. So we started that. We started building it up, and we'll show you some data about how that went. But as of last year, it switched over to a 3-digit number. So it used to be a 1-800 number. Now it's 988. And we're really excited and happy about how well that transition went. And I give a lot of credit to the two agencies who have built that service. Just for folks' awareness, that is not the only line you can call in Vermont in a mental health emergency or you're feeling some kind of distress or crisis. There's a crisis text line. If you've got youth who picking up the phone is traumatic and actually dialing it.
Some of the knows what that's like, right? Teacher.
There's the crisis text line. And then we have the pathway support line, and that is 24/7 and has been for a while now. And a lot of people find that to be the support that they really like.
Yes, I'm sorry, Jim.
So I live in far western Vermont on Lake Champlain. And when I call 911, it goes to New York. And they have to send it to Vermont, and I basically have to sit there while they're like, "Oh, we can't help you. Oh, let's get Vermont for you." And I'm waiting for Vermont now. And so I'm wondering if I was to dial 988 from my home in Western Vermont from my cell phone, which goes to a New York cell tower, would I be directed to New York 988 because of that cell tower, or would I be directed to Vermont 988 because of my geolocation?
Right now, it is based on the 802. So if you have 802 in your number, it goes to Vermont.
Oh, wow, that's a problem. Because I have 631 because 15 years ago when I got a cell phone, or 20 years ago, whatever it was, I happened to get it when I was home from college and on Long Island where I grew up. And so I got that. Now it's too difficult to change it because a million people know my number and that would be very hard. So is there any way so I would get Long Island's.
Get Long Island, yeah. They're aware of that. And so they're working on making it cell tower, which also doesn't sound like it's going to solve your issue. I think the difference though between 911 and 988 is 911 is designed to be a dispatch center. It's not a place that you call and talk about your feelings, right? And so 988, well over 90% of those phone calls require no dispatch. So you'll be getting a caring person on the other line who can talk with you about, it's when they will ask you, would you like some follow-up or do you need another resource? And then they might need to patch you over to Vermont.
But they would be able to do that seamlessly.
They would be able to do all of the listening, the de-escalation, the risk assessment, all of those pieces. It's standards that every state has to meet to be a certified National Lifeline Center. So you might not even know that you reached not Vermont until you said, you talked about an interest in follow-up and then that.
But they would be able to handle that even though they are in New York?
Yes, they're required
Okay,
to
great.
connect those dots.
Thanks.
Leslie?
So how does that get evaluated? I mean, you say required, that's cool, but then what's the follow-up for that we know that they're actually doing it?
Well, so it's a great question. We do have, we're in very close contact with the National Lifeline, and there's a lot of data that goes up to them, including percentage and number of individuals who requested follow-up. And so we have numbers called, we have satisfaction of the caller, we have, did they require a dispatch? We have, if they required a dispatch, was it voluntary? Did the person say, yes, I want someone to come out? Did we ever have to send someone because someone didn't want them? All of that data is collected. Can I sit here and say, I know for certain that every time somebody in New York, I think that the National Lifeline's really interested in that, and they're building it right now. And they actually have some pretty robust data reporting. So it's something we're following.
Yeah.
I will also just say there was a really interesting article, and I don't know if it was 7 Days of Vermont Digger, about one of the people that is at the center that's taking these phone calls. Really, really interesting. And, you know, just, I was grateful to hear and read about the type of people that are working these lines, and really grateful for them to do it. So you might want to dig up that article. It was heartwarming. Quite frankly, I wrote the woman a note. It's hard. I was like, oh man, this is great. So anyway.
I'm so glad to hear you say that. I think it's also a position we've never had before at the designated agencies, where you're there to talk. Usually it's to provide a service. And do I need to come out to you? So that's I've heard from the people who answer that line, they enjoy that role. It's a nice, especially breaking it up. Maybe I do that on a Wednesday.
Right. And do something else. Yeah. Brian?
Yeah, I'm just curious, like with 988, who is fielding the calls? Are those going to like those of us at existing hotlines, or is there a new place in Vermont taking those calls?
That's a great question. So there's 2 certified centers. We put it out to bid. The 2 responders happen to be designated agencies. So one is NCSS and one is NKHS.
So we don't know, so say the acronyms.
Northeast.
Yeah, can you say what they are?
Yeah, Northeast Kingdom Human Services.
Where's Woody when we need him?
Yeah, and Northwestern Counseling and Support Services in Bergen County. So Northwestern, they chose to broaden their crisis team and have their crisis team every day to answer that line. Northeast Kingdom Human Services covers nights and weekends, and they ended up hiring just a direct cure for staff for 988. This is what you do. So they did it a little bit differently, which I hope answers your question.
Yeah, it does.
Just a quick follow-up. What are the qualifications, the training for people who answer?
Yep. So thankfully in Vermont, when we looked to the designated agencies to say, can you meet this? They've met it and then some. So particularly because we started out with Northwestern Counseling, they were already crisis clinicians. So those are generally master's level clinicians. They have been trained to even be a qualified mental health practitioner. So those are the folks who meet the credentials to involuntarily hospitalize someone, which is a higher bar. They've been trained in different types of risk trainings like ASSIST and others. So we have our own state requirements, and then the National Lifeline puts some additional ones on there. So it's usually met by something called ASSIST training, but there's a couple other options.
Assist training, I'm sorry.
Yeah, ASIST.
Arts?
Yeah, do we have data so far on the calls they get like per month, anything like that?
You got it. It's probably
Coming.
right after this.
All right, okay.
Let's finish somewhere to rest and then.
Someone to respond.
I work for them, I promise.
Right. That's why you're sitting down there, Allison.
That's right.
Someone to respond. We talked about mobile crisis. That's going to be a new way to respond. There is some mobile response happening now in the state, so I don't want to deny that. This is a slightly updated model. Peer support staff is also someone who can respond, and then the designated agencies. Somewhere to go. You will have seen some action from the Department of Mental Health over the past year on the Somewhere to Go category. So we are talking about adding to our youth inpatient facility capacity. So specifically, we've been looking around to Lori's point earlier. Brattleboro Retreat is the only place in the state youth can go for inpatient. We've felt for a while that it'd be nice to have some additional options in the state. It's pretty far in the southern region if you happen to be the northern region. But also, we're really pushing integration right now, meaning that if you have some other need besides mental health, which often people do, you're not just in one little box. If you were trying to go into inpatient, but you were a youth with a medical condition that needed some support, Brattleboro Retreat does not have the capacity for that type of emergent care for medical issues. So it was a real barrier. It caused youth to sit much longer than anybody would ever want to sit. So we put out a request for proposals for specifically medical centers who could provide this service so that we could have that integrated care. The other request for proposals you'll see out there from us all are alternatives to emergency departments. You'll hear that in terms like PUCs or mental health urgent cares. CAHOOTS is another program that you'll hear about. That is something that we requested. These are both spaces and programs that offer a different place to go if you were needing emergent mental health care. So right now, if you were going to go somewhere, it would be the emergency department. We want sort of these off-ramps. We've met with different stakeholder groups, partly pushed by the legislature to say, we keep hearing that families are very upset about the wait in emergency departments for their kiddos. Mm-hmm. When we went to talk with them, we asked them, do you want us to work with emergency departments to make this a better space? How do you want this to go? And the vast majority said, we don't want to go to the emergency department in the first place. So I think there's a both and of if you are there, there's a way to support you in a better way, but we also want to have additional options. So that's alternatives to emergency departments. We have children's residential programming that we're looking at. That would be something the committee might be interested in with DCF, the Department of Children and Families. We're all working together to look at how often are we sending children and youth out of state to get that need met. Yep. So how can we do that better in Vermont?
Yep. So just a real quick note on that. So that is under the jurisdiction of Human Services, but again, we're going to be working closely together. So I'm sure we'll hear more about that as well. Can I just go back to the RFP for the youth beds? So it was awarded. Can you just give us a little bit of background? Because I know it's also in the BAA that we'll be looking at. So just a quick update, and then we'll have more time on that when we come back and talk about the BAA.
Sure. The current status of the RFP for inpatient is a feasibility status or a feasibility study. And right now that's happening at Southwestern Vermont Medical Center. And so they were the lone bidder to our RFP that we posted this summer. But the first step in that was to do a feasibility study to take a look at would it work for that facility and for that area and for the system. So we anticipate that to be completed soon. Very soon, and then we will begin, we'll take a look at that, we'll analyze that, and then begin the next steps towards contracting, if depending on the information in that feasibility study.
Right. So, I think you'll hear concern in the building that is, again, in southern Vermont, which is unfortunate, but at the same time, they are the only entity that responded to the RFP. So that will be something that, this committee will weigh in on, and because money will be needed from the legislature to move those beds forward. So just wanted to put it out there. We'll put it on the back burner for now.
Thank you.
Are we good?
Great. So just some updates around the two prevention positions. Do the Director of Trauma Prevention and Resiliency. This position is designed to be broader than the Department of Mental Health and serve the other departments. And we have been incredibly lucky to have Kaya Ganguly in that role. She's phenomenal, and she's trained over 2,000 people since coming into the position in June of 2021, and also created and developed many trainings. So she's serving as an advisor to the AHS Secretary's office, as well as she fields phone calls and goes out to do trainings for all sorts of community partner schools and colleges. And so another piece is there's a very innovative program that she's been co-creating and leading that's around learning collaboratives. And that's going out to all the district offices. And this is really about we're hoping it's going to help with staff retention. We're acknowledging that these roles, particularly in district offices, are really traumatic. You hear really difficult stories. You're put in impossible positions where families need something that you're not able to give them in the timeline that you would like to. And we have supervisors who are in a role to maybe support, but said all that difficult stuff in the context of COVID-19 and the pandemic, and it just felt like everybody was flailing. So this is a program to go out there and teach supervisors how to do trauma-informed supervision and be really responsive to the needs of their staff, so we can create a really good safety net under them and also do really good professional development. These are people we want to keep in the field and give a good ladder up. So that work is coming through the Director of Trauma Prevention position.
Great work. Questions?
Okay. We thought we'd give you an update about suicide prevention efforts. There was an expansion to the suicide prevention funding last year, and this allowed us to expand zero suicide. So if you haven't heard that term, in my next 2 slides, I'll give you just the brief kind of like, here's what you need to know, but we can always dive into it more. But for folks who aren't aware, this was a public sort of practice and policy around how to approach suicide prevention as a state. And we had some early adopters in the designated agencies. So 3 of them came on, about 5 years ago, or it's probably, I'm dating myself, it's probably like 7 now. And then we moved to 7 agencies. And then this year with the extra funding, we were able to do all 10. They're all at different stages. But what they're getting to is if someone were to come to my doors and your primary care office identified them as having a need for suicide prevention, I am confident that I have clinicians in this space who can serve them in an evidence-based, high-quality, suicide-specific way. So it's getting us to that place. If you come in my doors, we can serve this population. And we have seen some interesting data that since bringing in zero suicide, those connected to the designated agencies who are being served there, we've had decrease in numbers of people dying by suicide who are connected. So that's promising. As I mentioned, we have a director of suicide prevention. He started at the beginning of the new year. His name is Christopher Allen. He's been involved in suicide prevention in the state for a long time.
Is he a family practice doctor?
He has a private practice.
I know.
Yeah. It's a private practice. He's a licensed clinical social worker at the psychiatric hospital. So he really got a good education and there. But then he's also been involved in AFSP, which is the chapter.
American Federation of Suicide Prevention.
Yeah, so he's just, it's a passion of his. He has a real, I think he's just going to bring a lot to the table in this role. We'll talk about 988 data in a moment. And then the other piece that funding went to with that increase is we've seen some data over the years with older Vermonters dying by suicide at higher rates. The pandemic increased that concern because for older Vermonters, we had increased risk for leaving your home, therefore even more isolation. And that along with other, financial and health concerns can really increase stress and depression. So we have a program where mental health providers go out to the homes of older Vermonters and provide the therapy to them in their homes. And that money went towards expanding that program. The big news is we've had a CDC suicide prevention grant for since 2020, and that work is really going incredibly well, and that'll be something VDH can come and talk to you about, but we've partnered with them on it. And we also were just awarded the Garrett Lee Smith grant. So that is a grant for suicide prevention that's focused on children and youth. So as we know, that's in Vermont, everywhere we look, we're seeing increases in children and youth struggling, being more depressed, having more behaviors, and we're concerned that that's leading to more suicide deaths, and especially suicide deaths at even younger population, and that we've seen more 14, 15-year-olds, which is obviously really concerning. So this will be a dedicated effort towards that.
Great. And do you know how you're using that grant yet, or something to come back to?
It is in the beginning stages of pulling all the folks together, and VDH owns that grant with our partnership.
Okay,
Great.
Okay. When I say zero suicide, just so you can start picturing in your brain what that means, it's both a philosophy and an actual public health approach. The philosophy, which I'll name is somewhat controversial, is that there can be such a thing as zero suicide, which is us saying we think suicide is preventable. There are some who you might hear and will be trying to bust the myth, well, if somebody wants to die by suicide, they're just going to do it. And there's really nothing you can do. And this philosophy is saying that is 100% not true. You can, and I know in my experience, when you talk to people who have attempted, they're grateful for the intervention. Over 90% of people do not reattempt. And they're very glad that somebody noticed and cared enough to ask. And so I go by what they say. But there's also people who find the zero to be a little bit invalidating of their experience. And there's also assisted suicide and things that don't kind of are a little bit aside of that. So I just want to name that as something. But really what it means is that you have something at every level of somebody's journey towards potential suicidality. So we're talking everything from going out to schools at an early age, building resiliency in youth, because they're going to face life challenges and there's things they can learn to help them through that.
We have Leslie and then we have Art. Go ahead, Art.
This plan you show here, is this happening now or is this something you want to happen?
Happening now. The 3 agencies that joined have been doing it since about, I think it is 2016. We had 7 agencies start around 2020, and now we'll have all 10. So this has been in the works in pockets of the state
Okay.
for a long time.
Are you going to cover, here in a minute, universal screening?
What would you like to know?
I want to know if kids are being screened for suicide.
it's over here in the green.
So Leslie, sorry, answer.
Yes, so universal screening. So it's funny that you ask. The reason why I ask is that can make some people very nervous because
Makes me nervous.
It's tricky to treat everybody. If we started blanketing universal screening and you asked every child at every door that they walked in if they were suicidal, that can become very overwhelming. So what we're learning as a state and a system is how to do that in the right spaces. So when we go out and we teach communities and schools how to talk with kids, we're not talking to them about doing a clinical risk assessment. We're talking to them about, hey, if you see a child and they're really distressed, can you ask them in a developmentally appropriate way, like, how are you doing? Have you had any thoughts? It's then that if they give you the impression and they state that they're having thoughts, that they might get kicked up to the next level. A formal screening could happen anywhere in there, but if you mean our teachers walking around formally screening every.
Well, I just want what the screening system consists of and when it starts, what age it starts at. I mean, I just personally, I don't think kids need to even be aware of it. They don't know about suicide. They're happy and they go about their business. I get that there's, that's just me. I'm just questioning.
I get what you're saying. I will tell you that it has been proven that asking somebody about suicide doesn't actually trigger suicidality. But I will say that doesn't mean that we're going around asking 4-year-olds if they've had thoughts of ending
I
their
hope
life.
not. Okay.
So usually where that screening happens is when someone refers to a crisis team. And that they'll say, I have enough to go on here that I think something's going on.
Yeah.
And then they meet with a professional.
So we have, okay, hold on. We have Alyssa and then Joe and then Anna.
I've been thinking about this a lot lately, just because of various people that I've come into contact with. And I'm wondering, I know an awful lot about zero suicide. I'm wondering what the department is doing specifically and if there is a gap in care in sort of a crisis response to families, friends, community members who are close with those who have completed suicide. And what is the department doing in that regard? And should that not be included in zero suicide? Because we know that having a family member die by suicide makes you at high risk of dying by suicide.
It is a gap. It's been a gap in a way that it's been a gap in that it hasn't been systematic. So there's pockets of the state that probably due to a traumatic event and a death by suicide in that region, somebody has stood something up, but not something that we've been able to say as a department. If you called and said, well, this happened here, we've identified that as something where we don't feel there's enough what we're calling post-vention supports. So that's something that the CDC grant is actually really working on right now. And everything from, it's both the grief, but it's also, there's a lot of details and things, just stuff that you don't want to have to think about, but that you have to deal with, to have support with. So toolkits to hand a family to say, okay, like here's, to give to schools to know what message to send out. How should you support the other students? What shouldn't you say? What should you say? All of that, plus having groups and support places for somebody to go. So there's two places that's happening. There's the CDC grant, and then there's also the Governor's Challenge, which maybe I could just skip over to the Governor's Challenge.
That's the next slide, yeah.
Cool. So one of the things that the Governor's Challenge is, the governor reached out to us and said we need to join this, and it's specific to service members, veterans, and their families. But what it's doing is it's connecting us with other states and national standards on how we're managing suicide deaths and suicide prevention. And what we got out of that was, first of all, 20% of our deaths in 2021 were veterans in Vermont.
I'm sorry, what percentage was
20% of those who died by suicide were veterans. And that means they identified as veterans. So it's probably much more. And so we went down to work with this group, and one of the first people that came was post-vention supports, and it was family members of veterans who died by suicide. And they talked about this incredible network that they've built. And it's something that I think it exists, but it's been grassrootsy and hasn't been state run in many places. And they're now looking to us to say, how do you build this in a sustainable way? So it's being talked about, it needs more work. And I'm glad you brought it up.
Yeah, I would just offer that, it is not an acute thing that needs to be offered. It is a long-term thing.
Yep. Yeah, no, exactly. It's not some kind of,
it's not go into the school the next day and,
right.
you all seem fine and.
Yeah, and then exit. No, thank you for bringing that up.
Joe?
A comment and a question. First, to respond to Arts, when I was a professor, I got some training on this. Basically, if students come to you because they trust professors and they start talking to you about being very depressed or something like that, to ask, are you considering committing suicide? And the first time I had to do it was very uncomfortable.
That's different.
Yeah. But it was very uncomfortable, but it opened a door to then me literally walking that person down to the mental health center. And so it was very, hopefully they got the help they needed. But my question was, it seemed that you had said a few moments ago, and please correct me if I'm wrong, that a critical component of the screening is inside the primary care system. And so am I to understand that sort of when someone goes to their primary care, their yearly checkup, or they have a cold, just sort of like the doctor is just sort of like keeping in mind, like I'm just looking for certain red flags, and then sort of like I was just saying when I was a professor, then if they sort of see a red flag or if someone says something that might then sort of kick them over into a more formal assessment, is that what we're talking about here with relation to primary care?
We're working on having actual formal screenings in primary care. Most primary care screen for depression. That's generally what you're going to get. And then what's kicking it up a notch is the Columbia Suicide Scale. And that's a suicide specific. And it's actually really important to be asking suicide specific. There's a myth that everybody who's died by suicide has some sort of long-standing depression. And that's actually definitely not the case. And sometimes and often it's a life stressor that came up, a financial relationship. It comes into your mind and can be a very impulsive act. And so asking about suicide directly is very important. We're trying right now, this isn't a blanket requirement of primary care offices. What we've done is we did a mini grant program where we gave them a $5,000 opportunity to come and do a partnership with their local mental health agency. And we asked them, how would you identify it? If you did, what would you do? And let's talk to these people so you know who to call and make sure you're asking the right questions. And that's kind of how we're growing it right now.
It sounds like those primary care providers are a really important piece of this puzzle.
They are. Most people who've died by suicide in Vermont are not actively seeing a counselor or are not actively in our community mental health center, but they all have seen a primary care physician within some period of time.
I also have like a high level question as well. I'm sort of trying to save it to the end, so I just wanted to.
Okay.
Yep. Thanks.
Yep. Alan?
I'd like to know the relationship you have with the school systems with mental health. Is it a close relationship, or how do you go about dealing with the school systems with this?
Sure. Yeah. You want to talk a little bit about Success Beyond 6, and then I can talk about the higher level work with AOE?
Yeah, we have the Success Beyond 6 program, which is really the Department of Mental Health. You'll see in our budget pie, when you get a chance to really look at that, a big chunk of that is Success Beyond $6. That's funding that puts a mental health provider in a school. It's the designated agencies putting one of their employees in a school. They offer 3 services, school-based clinician, behavior intervention, and they also have an autism program. And so I would say on the local level, there's a lot of interagency teams, and they meet and talk, and they're discussing kiddos and youth all the time. They have things called Act 264 meetings, which if there is ever a child who everybody agrees maybe isn't getting what they need, mental health, education, and child welfare all come together, and that's required through Act 264. So I think at the local level, there's a lot of work happening. I do think we're trying to figure out what's AOE's responsibility for monitoring well-being in data versus DMH's, and with local control, I think it's tricky. So we do have some great data through something called the CANS, Child and Adolescent Needs and Strengths Assessment. And that's something brand new that we've finally gotten over the past couple of years, where we can now actually tell you what are the needs of the children getting these services? How are they doing over time? What's showing up as the biggest issues? And I can tell you anxiety has been the one that's growing the most. So that's the middle ground, if you want to take the higher ground.
Sure, and myself and Laura Omland work closely with Secretary French on planning for how to support youth in schools and how to, from a state level down to local control, and how to incorporate some of our vision and goals into the work that AOE is doing. And I think that that's a close partnership in order to support those youth. So we meet with them very regularly. Yeah.
And I would also encourage everyone to reach out to their local school districts. I know I talk to our folks quite often just to get a feel for what's happening in the schools and what their needs are. I mean, they would be really appreciative, I'm sure, of a phone call to say, hey, I sit on the healthcare committee. I want to know what's going on in your schools. So feel free to do that. Maury.
To the screening question, just to add that hospitals do unaccepted, I think we used my hospital, UVM Medical Center, used the Columbia screening tool, and they might have added another one, but it is very specific. And not everyone goes to the hospital. We don't want everyone going to the hospital unless we need you to, but at least there's another connection point.
And the Columbia is a nice model because there are, depending on the setting, there are appropriate screening tools based on where you're having that. So we use that as well at the Vermont Psychiatric Care Hospital on a daily basis for screening folks.
I just want to do a check real quick. So it's 10:15. I'd really like you to go through some of the 988 data, and then I'd like to save a couple minutes at the end for some questions. So if that's okay, and if there's something you really want to cover, let's do it. But if that's okay, and then, we always seem to have you come back to finish presentations. So that would be great.
Yeah.
Sure. So I gave you a little background on the history of 988. This is a timeline when Northwestern Counseling came on. And so I'll just highlight for you that across this timeline, at the beginning of it, we answered 0% of calls. around, the first dot, we got to about 35% of calls for Vermonters. And then now in July, we're around 86%. So any overflow goes to a group in New Hampshire called Headrest, and we work with them. We know who they are, and they provide data. So that's been also a really nice partnership.
Great.
And then here's some of the data. So one of the things I want to highlight, because obviously there's a lot of numbers on the slide, those slashes represent something that's been new. So what's new about 988 in the past even couple of months is we started opening up something called chats and texts. Texts are what you know of as texts. Chats are, if you've ever gone into a website and somebody pops up and says, do you need anything? Would you like that's chat. And so those are two different ways for people to access 988. Up until recently, all of that was handled by the National Lifeline Center. We've sought some grant funding to start building it in Vermont. So you'll see those numbers just start to tick up on the second dashes.
Okay.
But you'll see the response rate down at the bottom there. But I also want to highlight, we're showing you September, October, November, December, which is 531 calls, 720 calls, and so on. When this started, we were around 150 calls. And so it really picked up around January of last year. We started tipping the 350, 400, and once it went to 988, it almost doubled.
Well, and I think the outreach that EMH did has been incredible. I mean, we see 988 advertised everywhere, so.
Yeah, the front porch tour.
Go ahead, Leslie.
The front porch forum, sort of, my community is fabulous. So just so you know that's working.
Great, I did not know that.
Oh, yeah.
Yeah, ours too. Joe?
Clarification question. When we say answered here, do we mean answered by a Vermont agency providing help? Or do we mean answered by like just someone picked up and 11% of people just didn't get picked up in September?
I'm glad you asked that question because that doesn't happen.
Okay.
So it's always answered. It's just who answers it. And there's a rule. It's either 6 rings for 30 seconds. And once it passes that point, it kicks to headrest. And even if they didn't answer, there's a backup. So it's always answered.
But I still want to clarify something follow up on Joe's question. So we talked about the fact, like, for instance, depending on your area code, you may be going to New York. So are these this data is about 802 numbers specifically?
Right. So you'll see, there's calls received and then answered. So the denominator of received is anything that was routed to a Vermont call center.
Okay, great. Thank you.
And then on the bottom, you're just going to note that we are looking to offer follow-up. Some folks call and that's absolutely nothing that they're interested in, and they will tell you that right from the start. But if they are leading you in a direction where you think they might, then we would like to offer them that. And so we're looking at those numbers. We're looking at whether or not somebody actually needed a rescue of any kind. And then how many folks were at imminent risk when they called, but we were able to decrease that risk. And then the last piece that we wanted to make sure folks know, there are some people who are very concerned about 988, given that there's been experiences of 911 or police response that hasn't felt safe to some folks. And they were concerned that if they called 988, it might immediately dispatch police or ambulance. And also there's safety issues, and I think there's also shame and stigma. And so if you're going to call this line and then you're going to have sirens outside of your home, people are less likely to maybe pick up that phone. So we wanted to put some data out there ahead of time to try to address that concern. And just for folks to know that 1.2% required an active rescue so far out of the 2,608 phone calls. But of those 32 calls, 24 gave consent. So we will ask and try to work with folks to say, we would like to send somebody out. Can you give consent? If we do get to a point where a rescue is needed, they will send it. But that's the data on that so far.
Yeah. All right, Alyssa, do you want to go to Leslie first, or are you on this topic?
We're on the topic of suicide,
yes.
right?
Yep.
Okay. So I have a couple questions. First of all, Allison, I want to thank you so much for what you've said about, I mean, the myth, there are a lot of myths around suicide. And the fact that you said, you know, most people aren't really the people that you think. It's usually some sort of crisis or, you know, life event, life stressors. To that point, and I actually was reviewing the child fatality review board report that they give to the legislature every year. Of the suicides of youth, they were firearm, and in all cases, safe storage was an issue. So I'm wondering what the department is doing around safe storage. And kind of a two-part question. I mean, we know that 90%, in rough numbers, but 90% of firearm deaths in this state are suicide, and over half of suicides are firearms, even though they make up a tiny percentage of people who attempt suicide. So what is the department doing around both safe storage and also, you know, the issue of firearm and suicide?
It's been a big topic of conversation when we look at the data every year. The majority of suicide attempts are through attempts at overdosing using a medication, and the majority of those individuals survive. When we have a firearm, you're absolutely correct. It's usually lethal. Where we have worked is around counseling on access to lethal means. So one of the first things we talked about is, okay, if we think somebody's at risk, who might be the last person that they talk to? Primary care came up a great deal. If we actually talked with primary care, how comfortable are you asking folks about their access to lethal means? You know, we say, especially with a child, if you're sending home a prescription with a family that could be lethal if taken by a child, you need to have that discussion with them, right? Where are you keeping this? Is it in a locked safe? They're more comfortable having that conversation than asking about where a firearm is stored and how it's stored. And so we've been trying to get at it from that angle to say, okay, what can we do to increase your comfortability and also your knowledge? Because if you speak about firearms and it's clear you know nothing about firearms, your message is going to be lost on your audience.
Yeah.
And it can come across as pretty out of touch. And so there's work to be done about educating on what are good ways to store certain firearms, because some firearms can't be stored in every way, you know, and you'll hear my ignorance on the topic as I speak, but I've learned a lot in talking with sportsmen and firearm owners about those differences and their frustration in us trying to apply one option for what is a nuanced way of storage. So we've been pushing locks, we've been pushing safes, we've been pushing education, and then we've been pushing providers to engage in this counseling on access to lethal means so that they can have those conversations. I say we, but this has really been coming out of a partnership with the Department of Health. And they are the injury prevention group who's doing that education and promoting these different options.
And my last question, because you know I'm going to ask you this, 2021 was the worst year we've ever had for suicide. How's 2022 preliminary numbers looking so far?
Preliminary numbers are not looking like we're going to get any relief from this issue. They're not finished yet, but I expect it to be just about as high.
Can we have those as soon as?
Absolutely.
Thank you.
I'm going to go to Joe and then Leslie.
So this is a bit more high-level question. And one thing I'm very concerned about is the intersection of housing and mental health. So there was an article in VT Digger probably about 6 or 8 months ago at this point, which was about a gentleman in St. Albans, if I remember correctly, who had some significant mental health problems, but not to the level of having to be in an inpatient, and was being evicted from his home due to those mental health problems being disrupting the other people in the units that surrounded him. And of course, a landlord must provide quiet enjoyment to a tenant. And so if one tenant is disrupting the tenants around them, then that landlord sort of has no choice under quiet enjoyment than to do something about that disruption. And it really occurs to me when I particularly think about the unhoused, how mental health plays such a role in it, because it really is so hard to keep up a lease or to keep up a tenancy, to remember to pay your rent, to remember to pay your utilities, to not disrupt the quiet enjoyment of your neighbors, and on and on and on and on and on, things that we could list that if someone has mental health challenges could become a problem. And yet everyone needs a roof over their head. And yet our answer is that we don't have an answer, and for those people to be unhoused, and for those people to be on the street, and for all the other incredibly significant impacts that being unhoused occurs. And so I'm not looking for an answer here because I don't think we have an answer, but I'm really thinking about that population that just simply due to their mental health struggles can't maintain the basic requirements of maintaining a tenancy or ownership of a home. And yet the answer can't be live on the street. And so like, how do we help those people?
I think that's a really good question because there's significant housing gaps for numerous different populations of folks who are vulnerable. I know from an AHS perspective, AHS just hired a new housing director, and I think that will be helpful in coordinating and collaborating across the agency because as an agency, we're so large, all of our departments are touching probably almost all of the folks who are unhoused in one way or another. And so I see that as a benefit to the system. And so he was just newly hired. So I think we have some time before we're going to see the impacts of that position. From a DMH perspective, we have a housing coordinator who is actually retiring next week. And so we will be rehiring for that position, but then also taking a look at how we support folks who are unhoused and experiencing mental health challenges who might not necessarily be connected to a designated agency. So I think we have some work to do with that. So I acknowledge that for sure, and I feel confident that we're going to be making some positive gains here in the future with those initiatives as they come to fruition.
Thanks.
Yeah, thank you.
Leslie, you'll have the last question.
Yeah, I'll just be quick. Thank you, Alyssa. Those were really important questions because I'm really concerned about firearms and the lethality of that and what we will do legislatively about that. I'm interested. But you also mentioned a real increase in older adults. And I was just wondering if you could speak to that a little bit of, what you're learning and method and what we can do.
I would love, the Department of Health has some really great data briefs on this topic, and I think it'll answer your question. I know that there was higher proportion of older Vermonters utilizing firearms and a higher proportion with a disability, and a disability is highly linked to feelings of suicidality, chronic pain. You want to be doing things and your body is not following your mind. It can be really frustrating and make people hopeless. So those are two ingredients. And then there's also just this big issue of isolation. It's so much easier. We were finding people, we were looking for ways to get people out of their homes, reconnected. And that was a really tough thing to do during a health pandemic. So you'll see a few things to look out for, something called Sheds. It's a program to bring people out and working together on community projects. But it's the whole goal is to get people shoulder to shoulder working on something together, using some of the skills that they might have, particularly for a retired population. And then you have a couple folks in there who are trained on having good conversations so they can check in with people about their mental health.
So may I ask, is that coming through the Department of Health or you or a connection?
We're supporting it. SASH is the one leading the facilitation.
Thank you.
Good conversation. So there are some really still important things we will need to discuss that are in the presentation here. I'll just peer workforce we'll be taking up again. We'll give you the history from last session, but we're waiting for the report from the group that's been working on that. There's a lot in here on children and youth, and I feel like every time we have you come in, that's like where we just stop, and we need to make sure we dedicate time to just children and youth. So we'll do that. And then there's some exciting work happening with certified community behavioral health clinics. I was lucky enough to be involved in monthly conversations about it. And so I'm excited to get that in front of the committee as well to see where DMH is in that process and what you might need from us to move those along. So more to come. Thank you very much. We appreciate your time and we'll see you again soon.
Sounds good.
Thank you.
Your graphics are fabulous.
And